Welcome, everyone. Thanks for coming to my talk this beautiful evening. I know many of you would like to go for a walk and give your lungs a treat. Pretty windy, but it's nice to see the sunshine today. Thanks for spending your valuable time with me for the next hour and a half, where I'm going to give you a primer on lung disease. Even if you don't have any lung symptoms or lung conditions, is really good information about immunizations that we all might need at some point, depending on our age and conditions. And I'm sure someone you know, or a loved one or a friend, does have some lung symptoms or lung conditions that you can help them out with this information. And it's all for sharing with anyone you please. And I'd like to reintroduce Leona Cullen. So she's my partner in the Empowering Patients program over the last 10 years. So she works so hard behind the scenes to make it all happen. And she's got some valuable information about community resources and other things happening in the Burnaby community. So welcome, Leona.
Hi, thank you, Dr. Wong. I'm very happy to be here. We're showing some beautiful Burnaby cherry blossoms. So I love looking at those because 'tis the season for cherry blossom. So as Dr. Wong said, I will be sharing some information, just some links to information. So check out our chat. Starting with our Burnaby Division of Family Practice website. Dr. Wong, I'll tell you all about the division, but we're an organization that supports family doctors. So you can check out that site to see all the work that we have going on behind the scenes. I will also share our link to the Empowering Patients, again, shiny new website that has recordings of previous talks, our upcoming schedule. We have one more hosted in April. We'll talk about that later, and other resources that Dr. Wong so kindly shares with everybody. So feel free to download, print, and share those with folks you know. And then I'm going to share the Burnaby Primary Care Network's website. And the Primary Care Networks is a collaboration between the division, Burnaby Division, the Fraser Health Authority, and many community partners who do good work in Burnaby. And we that includes our urgent care centers. Do you know where to find them? We do have two. So all the information as to how to find the urgent care centers or UPCCs. If you're looking for a family doctor, I'll share a link as to how you can get added to the wait list and get a family doctor. Some community resources, as Dr. Wong said, including information on food and meals, folks with developmental disabilities, seniors, and if you have technology issues, there's actually even resources about how to get help learning new technology. I will do one plug. We have several community fridges in the community that help feed people in the need. So if you have a fridge in your garage that works and you would like to get rid of it and donate it to somewhere useful, reach out to me. I'd be happy to share with our team because we're looking for one more to place, I believe, up at SFU. I'm going to share a link to Dr. Wong's HealthWise column, which he's so kindly now sharing on our PCN website. So you can check out all the additions that have come up and our monthly newsletter called The Checkup. So all the good stuff that's happening in Burnaby, we put it together in a monthly newsletter so you can subscribe to that. And then my last pitch to you will be to sign up for our April 23rd. That will be a Thursday again, making the most of your hospital stay. So if you have an upcoming hospital visit, Dr. Wong's going to share how to make that maybe a little bit easier for you. So that's all I've got. Watch the chat and enjoy.
Great. Thanks, Leona, and thanks for all the work you're doing behind the scenes and in our community. So, what you should know about lung disease. And it's brought to you by us, the Empowering Patients program of the Burnaby Division of Family Practice. So the Burnaby Division of Family Practice is actually the members are the family physicians that serve the Burnaby community. So that includes some on the border with New West and Vancouver and some Vancouver doctors that look after the Burnaby community. So it's a nonprofit, and we're here to support the health of everyone in our community. So we work with a lot of partners through the Primary Care Network and all the other organizations that support the well-being of everyone in our community. So our education, so that's the division website, burnabydivision.ca. And this program is about empowering you with your health. That's a picture of my dad from a few years ago at our walk with our dog, one of our community events, encouraging you to be healthy and giving you the support to deal with healthcare providers and deal with healthcare conditions. So why are we here? As family doctors, we care about our patient and we care about our community. And that's why there is a Burnaby Division of Family Practice. And we care about the future, not only of healthcare, but everyone in our community as well. Today, we'll be talking about things that I think everyone should know about lung disease, but I'm sure there'll be some surprises for you about actually how does the respiratory system work? How do your lungs work? What are the really important symptoms you should watch out for respiratory conditions? What's the difference between pneumonia and bronchitis? What are different types of lung disease, including asthma, chronic bronchitis, emphysema, interstitial lung disease that many of you have not heard of unless you actually had it or a loved one has it. What are the symptoms of sleep apnea, which affects all of us, including myself? And what are the symptoms of lung cancer and how should we screen for those? And also some rare emergency conditions with the lung, including pulmonary embolism and pneumothorax, which most of you are not familiar with, but we'll make sure you know the key symptoms. So in case of an emergency, you'll recognize them immediately. Always start with redefining healthcare. So a lot of people think it's what you see on TV, like Chicago Med or Grey's Anatomy, the acute care, exciting stuff, all that drama in the emergency room and in the surgical room. But as family doctors, we know that a lot of the care goes on in the community, at our offices, and with other healthcare providers in the community. But who really provides most of your health care? And even if you do have a family doctor, it's not your family doctor, it's you. We're here to support you. You're the one that makes the decisions. And part of this program is to make sure you have the information and know where to get the resources and support to be your best self and to be in your best health. I believe that real healthcare is self-care because you're the most important provider. You're the quarterback. We're there to support you. And the best predictor of our future health are the habits we practice every day. And in our talks, we talk about the four foundations of good self-care. That includes what you put into your body, what you eat. And it also applies to things in our body that are not so good, like cigarettes, recreational drugs, and alcohol. We've had talks on what you do, physical activity balanced by rest, how you feel, emotional well-being, and finally, how we connect our healthy relationships. These four foundations really reflect the key areas of your self-care. And here's an example of the different talks we have, um, including surviving your hospital stay, which is the big topic for the next visit. So all of us will eventually end up in the hospital, even if we're not working in the hospital for some reason with a loved one, and we could be advocates for a loved one. So this particular talk can also be called the Lonely Patient's Guide to Hospital Land to get you acclimatized to the culture of the hospital and some of the key things that you should be doing, or you as an advocate for a loved one or a friend, to make sure you get the very best care and to make sure you stay informed and stay in control of your healthcare decisions. So we talk about a variety of common conditions like high blood pressure and heart disease and today lung disease, but also giving you tips on how to look after yourself and how to communicate with healthcare providers so that they give you the information you need and give you the support you need to be in your best health. So check out the Divisions of Family Practice website. There's lots of resources in addition to our Empowering Patients program and our past talks, both videos and the slides and the handouts. So as an empowered patient, what do you need for good self-care? That knowledge. And I'm here to provide you objective knowledge because I find that a lot of the information that's on the radio, TV, on your computer, online is quite biased or incomplete, with sometimes with ulterior motives of trying to sell you something or to drum up more business. And as a family doctor, we don't want more business, but we want our community, everyone in the community, to be healthier. So to give you that objective knowledge and evidence-based knowledge. We also need support from healthcare professionals as well as peers, other people with the same condition, because they're great supports as well. And then plan proactive care with a primary care provider, family physician, or nurse practitioner. So, what is health? Is it the absence of disease? I don't think so. It's more than that. So health is not the absence of disease, and healthcare is not the treatment of disease only. I believe we each have a positive potential. Every one of us has a unique potential in this life. It's your gift to the world, and it's our duty to realize that potential and to help others achieve theirs. That's a main reason why I am in medicine. Your positive potential doesn't mean being perfect, because none of us is, and it's guided by your personal values. So you need that knowledge, the support, and planned care. So on to the respiratory system. We all know about the lungs, but we'll go through a lot of the anatomy and the physiology, but in plain terms that in ways that probably haven't been explained to you before. So this is not a specimen of a lung, but it looks a lot like a lung. It's actually my orange from my lunch, but it looks a lot like the human lung. So the respiratory system is not just the lungs, but it starts all the way up in your nasal passages, your sinuses, the back of your throat, your trachea, and it goes down into the bronchi within the lungs and the bronchioles and the alveoli. So I'll walk you through the respiratory tract. So air enters through either the nasal cavity or the mouth, the oropharynx, goes down into the larynx, your voice box, and that's the upper respiratory tract. The lower respiratory tract is below the trachea, which branches into the main stem bronchi and then into the bronchioles. They fan out like a tree. And then we'll show you what the smaller subunits are in a moment. So each lung, you have a right and left lung. They're divided into lobes. So the right lung has three lobes, the upper, middle, and lower lobe. So as a physician, when I'm examining your lungs, usually when we're listening to the front of the chest, we're listening to the upper and middle lobes, middle lobe around the ribs on the right. And when I'm examining your left lung, the upper lobe we're examining on the left side, and there's a little strip called the lingula, which is kind of rudimentary middle lobe that's around your ribs on the left side. But when we're listening to your back, we're mainly listening to the lower lobes on both sides. So the right lung has three lobes, upper, middle, and lower, and the left lung, two lobes, upper and lower, and a little strip called the lingula. So air enters down the trachea and then extends down your throat and it branches into the right and left main stem bronchi. And these bronchi kind of branch out into bronchioles and they bring the air into these little air sacs that you can see on the right side of the screen. So these little air sacs are called the alveoli. They're really fine, membranous, round structures. They're little tiny air sacs and they have small blood vessels called capillaries. And so when there's contact with those capillaries, oxygen and carbon dioxide are passed through into the blood. So oxygen goes into the blood, and carbon dioxide comes out of the blood to the alveoli. So when you're breathing in rich oxygenated air, and then that oxygen is carried by your red blood cells, primarily hemoglobin. So we're looking at the heart. The pulmonary arteries receive blood that's depleted of oxygen from the rest of our body, and it enters the right side of the heart. The pulmonary veins carry the oxygen-rich blood from the back to the left side of the heart where it's pumped to the rest of the body. So we have two sides of the heart, two sides of the lung. So with each breath you take in, there's a muscle called the diaphragm. So the diaphragm is this big dome-shaped muscle that lies between your chest and your abdomen. So that's the part that goes into spasm when you're having hiccups. But it's working all the time. It's working right now. So when you're taking a deep breath in, the diaphragm contracts and it pushes the belly out. That's why when we talk about deep belly breathing, that's where you're usually using the diaphragm so your tummy comes out. And that draws the air into the lungs. Air passes from the nose and the mouth. The nose has mucus, which traps dust and other particles from entering the lungs. The air from the nose and mouth go down in the back of your throat into the trachea. And the trachea branches, as I mentioned, into the left and right main bronchi. And those bronchi branch out into bronchioles. And then it fills the tiny alveoli with air, where the red blood cells exchange the oxygen for carbon dioxide. And those little hemoglobin molecules in your red blood cells, they bind to the oxygen and carry it to the rest of your body. That's why if people are anemic and their red blood count is low or the hemoglobin is low, they feel more tired and short of breath because their blood is carrying less oxygen if they're anemic or their hemoglobin is low. So this oxygenated blood that's carrying oxygen from your lungs to every cell of your body, it powers your metabolism, the energy-making cells in your body, the mitochondria. So the cells break down nutrients such as glucose to create ATP, and that's the energy currency of your body. And we need that energy for just thinking, moving, growing, for pretty well every bodily function. And when you exhale, the diaphragm relaxes, your tummy goes down, and the air is passed up through your trachea and out through your nose or mouth. Air is passing through your vocal cords in the trachea, and then our vocal cords open and close, and that's actually how we speak and how we sing. So let's go on to key respiratory symptoms that we should all watch out for, and all of us have some of these at some time or another. So commonly we might ask if you're having difficulty breathing. We call that shortness of breath. We used to abbreviate it in our notes as SOB, but since a lot of people read our medical notes, we don't want to seem like we're saying bad things about the patient. So SOB in old-fashioned medical notes is not an insult to patients. It just means shortness of breath. So, but you probably won't see that anymore. We'll probably just call that dyspnea, dyspnea, medical term for difficulty breathing. We can find that with some conditions like asthma, chronic lung disease, which we'll detail in a few minutes. Anemia, as I mentioned, if your red blood cells are low, you'll have less oxygen and less energy going to your cells. And in heart disease, such as congestive heart failure or narrowing of the arteries, in heart failure when the heart's not pumping as strong, in lung cancers, in COVID infections, and other respiratory infections. So many, many things can cause shortness of breath or difficulty breathing. Do you have a wheeze? So a wheeze is a musical sound when you're breathing out, and I'm assuming your mouth is not attached to a clarinet, a trumpet, or a flute. So this could be a sign of asthma, kind of a musical sound as you're breathing out, or it could be a sign of bronchitis or obstruction of an airway. So there's many causes. Have you been coughing? So a cough is caused by any irritation in the respiratory system, in the airways. And that could be anywhere from the back of the nose or sinuses to the throat, to the trachea or the lungs themselves. So it could be something as simple as colds or seasonal allergies or a cat or dog or dust allergy, any form of postnasal drip from the nose or sinuses, from bronchitis, acute or chronic, from asthma, even from acid reflux from the stomach. So when acid refluxes up into the throat, we might feel heartburn, but sometimes it can be silent when we're lying down, and that bit of acid could tickle the back of the throat and cause some irritative symptoms like coughing or hoarseness of your voice. Of course, a cough is prominent in many COVID infections, in pneumonia, and other respiratory tract conditions, and respiratory tract cancers. Have you coughed up blood? So a common cause could be a nosebleed, but we don't want to assume that's the only reason. It could be caused by any kind of broken blood vessel, like from coughing really hard. But it could also be from a cancer in the nose, the throat, or in the lung itself. So we don't want to ignore that symptom. Bring it to the attention of a physician. So now that we covered the symptoms, we'll talk about certain lung conditions that we all should know about. So first category is airway disease. And I include chronic lung disease, chronic obstructive pulmonary disease, or chronic bronchitis or emphysema, asthma, bronchitis, pneumonia, and of course, COVID and other respiratory infections. It could be due to another category, lung tissue disease, such as pulmonary fibrosis or sarcoidosis, and I'll detail that in a moment. And also circulatory diseases, such as pulmonary hypertension or pulmonary embolism, and I'll explain those in a moment as well. And of course, lung cancer is an important thing to screen for, if you have risk factors. So let's start with some common lower respiratory tract infections, as opposed to upper, which is usually like a laryngitis or a cold or a sinus infection. Those would be upper respiratory. But lower respiratory tract infections include acute bronchitis, an infection of the bronchi, the main airways in the lungs. So the symptoms, of course, include a cough. There may be shortness of breath. There can be congestion in the chest, like the sense of mucus or fullness in your chest. And sometimes it can be productive of mucus and sometimes not. And sometimes we can hear wheezing when I'm listening with a stethoscope. Pneumonia can have similar symptoms, but it's an infection of the tissues of the lungs. So you can think of the tissues of the lungs, where the alveoli are, as more like the spongy tissue. So it has some different symptoms in addition to the cough and shortness of breath. There may be fever, but not always. There's definitely chest congestion. Sometimes there's production of mucus, not always. Sometimes there's wheezing, but not always. And sometimes there's chest pain, particularly with breathing. Pleurisy or pleuritis is inflammation of the lining of the lungs. So there's a membranous lining outside of the lung structure itself. These are called the pleura. And they can get inflamed for a number of different reasons, sometimes with infection, sometimes just spontaneous, and sometimes as a result of other inflammatory conditions. The common symptom is pain when you're breathing in and out. We call that pleuritic pain. So asthma is a chronic, often hereditary condition that's sometimes allergic as well. And it's reversible constriction of the bronchi or reversible airway constriction. We call that bronchospasm. And the symptoms, in addition to intermittent coughing or wheezing that we can hear when you're breathing out, there's shortness of breath with exercise, and it's sometimes triggered by allergies or exercise or cold air, and it's often worse at nighttime as well. It's diagnosed with what we call spirometry or lung function test, pulmonary function test. So pulmonary refers to lung. So pulmonary function test is a special test that's performed by respiratory technicians, experts in that area in our hospital. And usually we do specific measurements to look at different lung function. So asthma definitely is diagnosed with spirometry, and another thing called a methylcholine challenge, which is part of the pulmonary function test. And the key feature with asthma is symptoms are not always present. They're kind of intermittent because the spasm of the bronchi, that bronchospasm and the wheezing, isn't there all the time. It's treated with a variety of inhaler type mechanisms. There's bronchodilators that open the airways for the short term, like Ventolin, the little blue inhalers that you see commonly. It can be treated with inhaled steroids to reduce the inflammation of the lungs. And it can be treated with long-acting bronchodilators that cause sustained opening of the airways and combinations of both types of medications. And sometimes we use oral medications such as Singulair, commonly used in kids. It's a special antihistamine that's particular for asthma. And prednisone, if someone has a very severe attack, not responding to the bronchodilators and the anti-inflammatories and the long-acting bronchodilators. So it's important for people with asthma not to rely on just the short-acting bronchodilators because they don't treat the underlying inflammation. And if someone has poorly controlled asthma, such that they're needing to use those rescue bronchodilators frequently every day, that can cause some chronic changes in the lung that are very similar to chronic bronchitis or emphysema. So it's important if you do have asthma, make sure you do have an action plan and know when to use your different type of inhalers. So there's so many different mechanisms that you can use for um, getting that medication into the lungs. This is just an example of a few. Chronic obstructive lung disease, or COPD, can include chronic bronchitis and emphysema. So there's irreversible constriction of the airways and inflammation of the airways as well. So sometimes people present just with a lot of wheeziness and shortness of breath all the time. And these people are obviously wheezing when we listen to their lungs. But some people with chronic lung disease, their lungs are quite quiet, but they're still short of breath. So emphysema is kind of a subtype of pulmonary lung disease, difficult to diagnose just clinically by examining somebody. It's usually seen on chest x-rays or CT scans of the lungs. They're treated in similar ways. Often people with chronic lung disease, when we do the x-rays, they are hyperinflated. So just to compensate when they take a big breath in, it's a super deep breath in. So sometimes there'll be a comment on the chest x-ray of hyperinflation. And that in some cases could be an indication of chronic lung disease. And chronic lung disease can be caused by cigarette smoking. That's the biggest risk factor, but it could also come with aging, with exposure to um, toxins like air pollution. And also some people are at higher risk, like firefighters or people that get a lot of um, exposure through occupations. So what are the symptoms of chronic lung disease, both chronic bronchitis and emphysema? A chronic cough that doesn't necessarily get better, but could be worse with respiratory infections. There's often a production of mucus in the morning, not always. Often shortness of breath with exertion, like walking up the hill, walking up the stairs, or doing more intense exercise as well, like running, jogging, playing badminton or pickleball. There can be shortness of breath at rest when it's severe, and frequently it's a lot worse when you have a respiratory infection. Even a common virus can cause a big flare-up in your chronic bronchitis. And sometimes there's chronic wheezing, but not always. So we diagnose chronic bronchitis and emphysema, chronic lung disease, with that similar equipment at the hospital with the respiratory technician, pulmonary function test, or spirometry. And of course, an important part of treatment is smoking cessation. If you are a smoker or know a smoker, check the quitnow.ca website. It's gone through a lot of updates and there's a lot of resources. There's even self-help programs and group health programs that are available and a lot of support and counseling. So big improvements in the Quit Now program. So check out the website if you are a smoker and are interested in quitting, or if you know a smoker. So a variety of inhalers can decrease the inflammation in the airways, and that can prevent worsening or decline in your lung function over time. There's also respiratory rehabilitation available as an outpatient through a lot of our hospitals and our communities. So that's to assist you in more efficient breathing. And then people with severe or end stage chronic lung disease have lower oxygen levels. And if it's sufficiently low with testing by a respiratory technician, those people might qualify for home oxygen. So a variety of treatments, including bronchodilators, anti-inflammatories, and a variety of other medications that treat the underlying causes of chronic bronchitis and emphysema. So there's a variety of respiratory vaccines that we should all know about because you don't have to have asthma or chronic lung disease to qualify for them because if you're over 65, you qualify for the pneumonia vaccine. So as I mentioned, pneumonia is an infection of the substance of the lungs, the tissue of the lungs, but the pneumonia vaccine is for a particular bacteria called streptococcal pneumonia, and the vaccines are designed for particular strains of that strep pneumonia. So it doesn't mean that you will not get other types of pneumonia, but it reduces your risk for serious, complicated infections with particular strains of Streptococcus pneumonia. So in BC, everyone over 65 qualifies. We used to have the Pneumovax or Pneumo 23 vaccine, and then the Prevnar 13 became available. And then the latest is Prevnar 20, and it was announced, I believe, last year that the Prevnar 20 is now available, publicly funded in BC for everyone over 65. If you're under 65 and a resident of a residential care or assisted living facility, you would qualify. And other people with certain chronic conditions who are at increased risk for infection with strep pneumonia, such as asthma and COPD, also qualify for the free vaccine or publicly funded Prevnar 20 vaccine. So even if you've had the Pneumovax before with your family doctor, check with your family doctor or your pharmacist to see if you should get the Prevnar 20, which covers more strains than the previous Pneumovax. There's another vaccine that's available, but it has not yet been publicly funded in BC. It is covered in some provinces. So the RSV vaccine gives you protection against respiratory syncytial virus. And in recent years, we've seen a lot of people in the hospital with pneumonia or complicated lung disease due to this virus. So there are three vaccines that are available in Canada right now. They're listed here: Brisvo, Arexvy, and Resvia. Uh, they are expensive, $230 to $300. It's just a single dose for most people, so you don't have to get it every season. Currently, it's recommended for pregnant women between 32 and 36 weeks of pregnancy. It's recommended for people over 75 years of age. And it's recommended for people between 60 and 74 with risk factors such as heart and lung disease or liver disease or in long-term care. So not yet publicly funded, but recommended if you can afford it. Some people have extended medical benefits, and in some cases it might be partially covered or covered with your plans, but it's not universal. And hopefully this may be covered in the future, but not currently at this time in our province. So lung cancer, there's two ways that you can get cancer in the lung. It can be primarily a cancer that arises within the cells of the lung. We call that primary bronchogenic carcinoma. You can also get lung cancer because it's a common place for cancers elsewhere in the body to spread to the lung, and that's metastatic lung cancer. So originating from a cancer that started somewhere else in the body. Sometimes people have no symptoms, and we just instantly find a nodule or something suspicious on a simple chest X-ray, or it might show up on a scan like an MRI or a CT scan. Sometimes people have symptoms like a chronic cough. So if you've had a cough for a number of months without an obvious cause, do check in with your doctor, particularly if you're older or have other risk factors like smoking, or if there's other symptoms such as unexplained weight loss or coughing up some blood or see some blood in your sputum, or if you've been feeling an increase in shortness of breath that's been gradual and progressive and unremitting, or wheezing for no reason when you don't have asthma. So all these symptoms can be suspicious for lung cancer. And if you have any of these conditions, such as a chronic cough or increased shortness of breath or weight loss, don't hesitate to see your family doctor so that we could do appropriate testing. So people that have smoked a number of years, like a pack a day or half a pack a day for 15, 20, 30 years, are at increased risk for lung cancer. So in recent years, BC has set up a lung cancer screening program. It's with a low dose CT scan, usually done annually in people that meet the inclusion criteria. So those would be people between 55 and 74. They have a healthcare provider that they can follow up with. They have a smoking history, um, and they have to meet certain criteria based on a questionnaire. So to find out if you might be eligible, you could check this website at the BC Cancer Agency. You can use that website or you can call that phone number, and then someone will kind of go through the screening to see if you might qualify based on smoking history, your age, and a few other criteria. And another important common symptom from young to old is obstructive sleep apnea. So this is where the soft tissues in the back of your throat, including your tongue and the soft palate, the roof of your mouth, they either narrow or they close when you're sleeping, and they block the flow of air into the back of your throat in the trachea. And this will happen when you're sleeping, when you're all relaxed. And the most common symptom is tiredness, which is a super common symptom. So we always keep that in mind. I always ask extra questions when a patient is presenting with increased tiredness or daytime drowsiness or sleepiness. Um, if they report loud snoring and choking or gasping during the nighttime. Um, Most people don't realize they're snoring unless they snore so loud that they wake themselves out or the neighbors complain. It's when you're sleeping with somebody else that your partner or your neighbors or the rest of the family will let you know that you've been snoring. And likewise with choking or gasping or holding your breath during the night, you may not be aware of that. Some people do describe waking up feeling like they're choking, but many people are not aware of it. So we kind of rely on the rest of the family or bed partners to tell us. Sometimes you might have morning headaches, feel like you had a full night's sleep, but you're still feeling you didn't get enough rest and you're still more tired in the morning than you were when you went to bed. It could be restless sleeping with frequent awakenings during the nighttime. But the key symptom is this drowsiness. And it's so important to recognize sleep apnea because it is a major cause for accidents. And we never know how unalert we are. Just like if we had too many drinks, we don't know how we're impaired, how much we're impaired. We underestimate our sleepiness and drowsiness and alertness. I had a young patient, he doesn't have sleep apnea, but he just didn't get enough sleep. And then he fell asleep at the wheel. Fortunately, he wasn't badly injured, but totaled his car just because he didn't have enough sleep. So so sometimes we don't know if we're alert enough to get behind a wheel. It can cause cognitive impairment, like a bit of brain fog as well. Many causes for brain fog, but this is a very treatable cause. It's a main contributor to increased blood pressure as well. And of course, marital discord. So we can diagnose sleep apnea with something called the HSAT, home sleep apnea testing. So that's some equipment you can borrow from a sleep lab. So that's a fairly easy way of testing. So this equipment checks the airflow through your nose. It could check your oxygen levels with a pulse oximeter. So it could tell if your oxygen levels go down intermittently during the nighttime. And it could detect how many times per hour you stop breathing. A more detailed type test is the polysomnogram. So that's an overnight stay at some of the sleep labs where you're actually sleeping overnight in the lab and they're detecting a lot more things. There's usually an electrocardiogram at the same time, blood pressure monitoring, assessment of your movement during the nighttime. So a lot more than the home sleep apnea testing, but much longer wait to do those tests. So the most common test is the HSAT, the home sleep apnea testing. And there are numerous labs competing to get your business to do the sleep apnea testing. And that's because the machines for treating sleep apnea, which I'll go through in a moment, are very expensive. They range from $1,000 to $2,000. So that's a lot of money and quite a big profit. And that's why there's so many companies willing to do the testing where they don't make a lot of money, but they can sell you the equipment, which is very expensive. sometimes covered by extended medical, but not everyone has that luxury of benefits and have to pay out of pocket. So sleep apnea can be treated with weight loss because sometimes being overweight can be a cause, but a lot of people that are not overweight still have sleep apnea. Um, the sedatives that make you more sleepy and sleep more deeply, like alcohol and sleeping pills and other medications that make you drowsy, can increase your risk for sleep apnea. And we often get people to sleep on their side because we usually find that the machines will record if those episodes are happening when you're on your back or when you're on your side. And most of the time, it's dependent on position. So sleeping on your side would reduce um, those periods where you have apnea for most people that do have sleep apnea. So a quick, cheap fix that sometimes works is a tennis ball and a fanny bag. So if you're wearing a little fanny bag or a little backpack to sleep, when you roll onto your back, you will probably unconsciously roll back onto your side because it's too uncomfortable. So that's one way to keep on your side when you're sleeping. And there's also more expensive devices that can keep you sleeping on your side that you can see on the internet and order from Amazon as well. There are also oral appliances that you can put in. There's some ones you can get over just on online or the internet, but the better ones are designed by dentists for your teeth. And the oral appliance pushes your jaw, your mandible forward, and that can prevent your tongue from falling back into your airway, even if you are sleeping on your back. So the oral appliance, also quite expensive, can be used to reduce sleep apnea or treat sleep apnea. So that's an example of an oral dental appliance to push the lower jaw forward and to keep those soft tissues from falling back into your airway. And there's an example of something you can use, the strap on, so that you're staying sleeping on your side. So the most common treatment that people will try and why there's so many sleep apnea testing clinics is the CPAP machine. So it's a machine that doesn't blow in oxygen, it actually blows in air into your nose in the back of the airway. So you can see that little green streak in the diagram. So that's the air passing in through your nose. It will go through the back of the nasopharynx and down your throat and bypass any obstruction in your airway to keep things open. So not everyone can tolerate those machines. The new ones don't make a lot of noise, but it can be uncomfortable, and you might have to try different types of masks. Some people use just nasal CPAP, just nasal cannula that push the air through the nose. Some people have to use a full face mask if they're mouth breathers as well. Um, so it takes some getting used to having that type of equipment. And so I usually recommend referring people to sleep apnea testing clinics that might give you a 1 month trial of the machine before you commit to buying it. So you do really need to try it out to see if it's something you can tolerate. And they could try different masks to help. Some clinics charge a lot of money just doing a 1 month trial, like $100 or $200. But there are some clinics that don't charge anything for the trial as well. So I prefer to refer to the clinics that aren't charging the patients much up front in order for them to do a trial of CPAP therapy for 2 weeks or a month to see if it's something that they can tolerate and also to make sure it makes them feel better because that's the key, that they can wake up refreshed and alert and their blood pressure is better if they have high blood pressure caused by sleep apnea. This is a common questionnaire that patients will be given before they do the HSAT, the home sleep apnea testing. It's called the Epworth Sleepiness Scale. So it asks you, how likely is it for you to fall asleep if you're sitting and reading, watching television, sitting in a public place, for example, in a movie theater, meeting, or your daughter's dance recital, if you're a passenger in a car in an hour without any break, if you're lying down to rest in the afternoon, if you're sitting and talking to someone, if you're sitting quietly after lunch, when you haven't had any alcohol, or if you're in the car stopped in traffic, how likely is it for you to fall asleep? So on a scale of 0 to 3, being 3 being high chance of dozing off, and then um, so if you score 18 or higher, that's severe sleepiness. If you score 11 to 14, mild sleepiness. So score 11 or higher, you should consult with a family physician. So you could Google that Epworth sleepiness scale and you can rank yourself with those questions and see if you should talk to your doctor about a referral to one of those sleep labs. So interstitial lung disease is progressive scarring of the lung tissue itself. We sometimes can see it on chest x-rays. And the symptoms are really, really subtle, and it's not caused by smoking or other risk factors that people are aware of. But it can be a common cause for shortness of breath, and it can worsen over time. So the symptoms might be shortness of breath at rest and worse with exertion, like walking. There could be a dry cough. It could be from our chest x-rays or CT scans or pulmonary function tests to confirm. If it's untreated, though, it can cause pulmonary hypertension or increased pressure in the pulmonary circulation. It can result in heart failure because the heart is pumping against greater resistance, and it may just make the muscle of the heart fatigue. And of course, it can cause end-stage respiratory failure as well. So there's many causes of interstitial lung disease. Common causes long-term exposure to hazardous materials such as asbestos, silica dust, grain dust, or radiation treatment, such as we might use with cancer. Autoimmune conditions such as rheumatoid arthritis, sarcoidosis, scleroderma, and Sjogren's syndrome, they can cause spontaneous interstitial lung disease. And there's some medications such as amiodarone, which is a drug to treat irregular heart rhythms, or chemotherapy drugs for cancer, or rituximab, which is used to treat autoimmune conditions and B-cell lymphoma, and sulfasalazine, which is used to treat inflammatory conditions. Pulmonary thromboembolism is a medical emergency. That's when a blood clot blocks the flow of blood in an artery of the lung, because that blood clot is kind of like a lung attack. So what it does, it blocks the flow of blood that supplies an area of the lung, and that tissue of the lung can infarct or die. And if it's in a particular key artery in the lung, that can result in death as well. The usual cause is a blood clot within the deeper veins, what we call a deep vein thrombosis or DVT. They originate within the deep veins in the leg. So a symptom might be pain and swelling of one leg. And that's why we pay attention to those symptoms as well and do screening tests to rule out venous thrombosis in your lower limb, because we know if we don't treat it, it can lead to a pulmonary thromboembolism. But that's just an illustration of what it might look like. So pulmonary arteries are illustrated in that bigger diagram. And an embolus is just a little blood clot that shoots down through the circulation and can block the flow of blood downstream. The symptoms can be a cough that might be blood tinged. There's often a rapid heart rate, excessive sweating, commonly chest pain, definitely shortness of breath, often lightheadedness, and then sometimes leg pain and swelling if it originated with a deep vein thrombosis. So this would be a medical emergency if there's acute shortness of breath, with or without the other symptoms of rapid heart rate or sweating or chest pain. So in the emergency, they would assess the risk, they would do some blood work, and they would probably do a CT angiogram, which is a CT scan that shows the circulation within the lungs. And it's treated with anticoagulation. So that's medication that dissolves the clot. Initially given subcutaneous through injection, and then given by mouth. And often treatment can last for 6 months or longer. And if it was not provoked by a particular risk factors, then some people are on lifelong anticoagulant medication. And pneumothorax is another medical emergency. So that's the collapse of a portion of the lung. And it's when air leaks into that space between the lung and the chest wall. Remember that pleura, the lining of the lungs. So if air escapes and leaks in that area, that air expands and then pushes on the lung and the lung collapses. The symptoms are a sudden shortness of breath, and there's particular signs when the doctor is examining the patient. There won't be any breath sounds on one side of the lung, the right or left side of the lung. And there's particular things we hear when we're percussing or tapping on the chest. There's increased echo or tympany that indicates that there's extra air that's trapped in the lung. So it could be caused by blunt or penetrating trauma to the chest, such as a fall from a ladder, a motor vehicle accident where you hit the steering wheel, stabbing, even from a medical procedure, such as acupuncture. If the needle is put in the wrong place, like between the ribs and too deep, it can result in a pneumothorax. Or it can be spontaneous without any cause. There's some people that just spontaneously get a pneumothorax. I've had a number of patients that have had that too, and they undergo special procedures to prevent that. So the treatment, of course, if you have the symptoms, sudden shortness of breath with chest pain, of course, 911, and in the emergency, they would diagnose it and treat it. And the treatment is inserting a needle into that pleural space to relieve that trapped air. And what we call a chest tube would be a bigger needle or a trocar, and it's connected to um, a bottle that would actually collect all that excess air. So, as we're coming to a conclusion, just a reminder that we each have a positive potential. And I think we each have a duty to achieve our potential and to help others achieve theirs. And that's the reason why I'm here today. I believe that with knowledge, engagement, and support, we can manage chronic health conditions and live well. We can still live our potentials. And just a reminder of a very common chronic condition that everyone in our audience has. It's incurable, it's sexually transmitted, it's also genetic, and it has 100% mortality. And of course, that condition is life. Let's make the most of it. And I invite you to share any valuable information that we've talked about with your friends and family. And remember that you're a part of our expanding circle of care, and you're part as caring for our community as well. So that's the whole point of our Empowering Patients program, to empower you with the information you need so that you can get more out of your healthcare providers, from your family doctor, when you're in the hospital, that you can advocate for yourself. And that will be the topic of my April 24th talk, the Lonely Patient's Guide to Hospital Land. So kind of the inside story of who everyone is in the hospital, how to identify your primary healthcare provider when you're in the hospital, the key questions you should be asking for yourself or if you're the advocate for your loved one in the hospital, how to make sure your wishes are respected, and how to get all the information you need to make the best healthcare decisions. So we talked about all of that in our next talk on April 24th. And I've left a lot of time for questions. So hopefully there's some questions in the chat that Leona can highlight for us. Oh, you're muted, Leona.
I'm muted. Rookie move there. Rookie move. Thank you, Dr. Wong. That was really super informative. Actually, some of my family members popped in my mind just with some of the symptoms and such. So thank you. Questions in the chat. Is the Prevnar vaccine a once only vaccine?
Yeah, for most people it's once only, although there's some people that could be immune suppressed that might require more. So you could always consult with your respiratory specialist or your family doctor to ask if you need a booster.
Okay, great. Thank you. Pneumonia vaccine, do you have to get it every year?
So Prevnar is an example of the
That,
pneumonia vaccine. So
okay.
that's not needed every year,
Okay.
unlike
Great.
the flu shots
Sorry.
and the COVID shots.
Okay. That's great. Good to know. What changes, if any, have you seen with lung ailments like cancer with adoption within the availability of smoking cessation methods?
So have I seen a decrease in lung cancer with smoking
Yeah.
cessation?
Yeah. What changes, if any, have you seen with lung ailments?
Um, I see lung cancer seem to be much less common than when I started practice 30 years ago. Mainly not so much with smoking cessation availability, but because of changing culture, the greater recognition of the risks of smoking and laws that prevent us from smoking in most public places. Um, it was surprising, but when I was in medical school, I even had colleagues that were smoking and needed smoking breaks between our lectures. It was like crazy.
Oh
And I'm
dear.
sure I have colleagues that drink too much still too. But that's funny. And so smoking, I found that fewer and fewer of my patients are smoking, but some are still smoking. We talk about the rest. It's nicotine is super addictive, and and vaping is not good a substitute. So a lot of young people are vaping with nicotine, which is so addictive as well. Even nicotine replacement, the gum is addictive. I've had patients that are
Wow.
addicted to the gum who were not smokers. So it's really hard to quit with that because you're not going to use nicotine replacement to quit.
Right.
Just because nicotine kind of gives a sense of well-being, it increases energy and alertness, it suppresses appetite. So there's young women tend to smoke a little bit more than they used to. Especially young women might start smoking in high school if their peers do, just to control, not to be cool, which is why boys used to smoke in the past, but to suppress appetite and control weight. So, and then it's so addictive that's hard to give up that habit after many years. And like all addictive things, the use tends to increase over time. So you get more of the
Yeah.
effect. Like Leon,
Yeah.
I'm sure you've never smoked before, but if you were to have a dose of nicotine, it'll probably knock you out and you'll feel like you're overdosed on nicotine. You'd probably feel really hyper and feel really sick. But a person that's been smoking or abusing nicotine won't get the same effect as the first time that they tried it. So like all addictive things, you get tolerance and then dependent.
Independent. I
Mhm.
tried it once in grade 5. Didn't take. So how do you diagnose bronchitis and pneumonia if the symptoms are so similar, and do you treat each differently?
Usually it's from the doctor examining you. They use similar antibiotics, but then pneumonia, this has been kind of a very interesting season because the respiratory um, infections with viruses and bacteria this year. I was talking to a friend who works at Broker Radiology, so he's seen lots of people coming in with pneumonia symptoms getting chest x-rays, and the x-rays are clear, even though they seem to have the signs of pneumonia, like
Wow.
the wheezing and decreased air entry to a portion of the lung. So usually doctors are pretty confident in diagnosing pneumonia, but this past season, there's a lot of people with just really bad bronchitis that present physically and symptomatically with the same symptoms as pneumonia, like chest
Wow.
pain, productive cough, and then decreased air entry and wheezing and crackles that we hear when we're listening to the lungs. So with our stethoscope, we hear all kinds of things, kind of inspiratory crackles are a common thing. It's like a crunchy sound that we hear in a lung that has pneumonia. And we also percuss the chest. And when we hit an area that sounds more dull, that's an area that's more likely to have pneumonia. So the clinical exam. Unfortunately, with so much telemedicine, even people with respiratory symptoms aren't getting in to see their doctor. But if you have the symptoms of a lower respiratory infection, like a bad cough that's not just in your nose and throat and sinuses, and you're coughing up a lot of mucus day and night, feel short of breath, hear some crackling sounds or wheezing, or maybe not, then you should see your doctor in person, not telehealth. So you can go in
Right.
and we can listen to your lungs. And if we suspect, if it's just a bronchitis, then we treat it with antibiotics and make sure the patient recovers after the 7 days. If we suspect pneumonia, we're going to do a chest x-ray. And when we do a chest x-ray and see a pneumonia, we want to repeat that chest x-ray until it's cleared, because sometimes there could be an underlying condition like cancer that could be underlying and have a similar appearance. So that's the biggest important thing about pneumonia, is that if we see abnormalities on the chest x-ray, we repeat the x-rays in a month to make sure that it's all cleared and make sure there's no underlying condition like lung cancer.
Right.
And people ask about walking pneumonia, and that's actually the majority of pneumonias in healthy people, that you'll have pneumonia and not end up in the hospital. Doesn't mean you can walk around easily, you'll still be short of breath. But it's just super common, especially when you're healthy and young. So we're seeing more people the past 3 years coming into the office wheezing, and which is really unusual when they never had asthma. And so we've seen lots of people the last couple years, the last couple of falls and winters, with more wheezing than we normally would hear, and more symptoms that suggest pneumonia that isn't pneumonia, but still a lower respiratory tract infection.
Interesting. Interesting. Bit of a mystery.
And people seem to have forgotten all the things we learned during the pandemic of how you pass infections around. So do not cough on other people. Don't cough in your hands and then touch things. Cough into your arm. And don't rub that arm onto anything, but make sure you clean
That's
afterwards. And if you do have a lot of coughing or sneezing, wear a face mask to protect other people. So don't spread it to your loved ones, your friends and coworkers, and people that are more vulnerable, like the elderly or people that might have kidney or heart disease or diabetes, that might be at risk for a more serious infection than you have with the same organism. So
right.
yeah, and wash your hands carefully before you eat, because there's things around, and yeah, a lot of people have forgotten all the things that we learned during the pandemic.
Yeah.
These infections are not as contagious as COVID, but the basic things that we learned with simple face masks, not the N95s, are still helpful. And COVID is still out there as well. So if you're at higher risk for complicated respiratory infections, do seriously consider getting the vaccine if you haven't had any bad reactions to it before. It gets updated every season because the virus is changing over time.
Right. Yeah, it's going to be that season again. Okay, another question. Can a person at risk for COPD do anything to decrease their risk other than quitting smoking, like exercise or anything?
Yeah, so that's where respiratory therapy comes in. So respiratory therapy includes exercise and something called uh, uh, spirometry, where it's not testing anything, but it's incentive spirometry, where little device where you blow and this little ball goes up. It's lots of fun to do, but it helps improve lung function. And there's lots of coaching from respiratory technicians that can coach you on how to get through a respiratory infection or an exacerbation of chronic bronchitis. So definitely worthwhile respiratory therapy for people with moderate to severe chronic bronchitis.
Cool. I could handle that kind of exercise.
In addition to your regular
In
exercise.
addition to my regular, of course. Should someone who smoked for 34 years, 30 pack per day for years, but now quit for 2 years, but is under 55, apply to be screened by the lung screening program, or are the eligibility criteria precise?
Well, you should, if you're 55 and up, then you would qualify. You probably would qualify. So you should check on the website and then make an appointment, and you'll get through the screening test to see. But I would think that type of history does have significant risk, even though you've successfully quit smoking. Congratulations.
Mhm. No, that's a big deal. What
Um,
change? Oh, sorry, go ahead.
I was just remembering when I was a kid, I didn't like bowling, not because I didn't like bowling, but because everyone was smoking in the bowling alley.
I remember that.
And I remember at the P&E as a kid getting burnt by someone's cigarette.
Oh, God. People
And
are
my,
terrible
yeah, and
sometimes.
my parents were non-smokers, but when they came back from a party with other grown-ups, they would have to air out their jackets and
Yeah,
coats because it would be so smoky.
yeah.
Yeah.
Driving in the car, my both my parents smoked, and when we moved to BC, we would be in the car on a long drive, and they would both light up. And because it was raining and cold out, we couldn't open the window, and so we would both, my brother and I, would be under our coats trying to find some fresh air from under our coat. It was not fun, but
Oh, a lot of secondhand smoke.
oh, a ton, yeah, yeah, it wasn't great. What changes in symptoms have you seen with the different strains of COVID?
It doesn't seem to be as severe. So, so we don't see as much of the like the whole body aches, fatigue, and brain fog that we used to see. But I still get my new COVID vaccine every year because have so many patients and I hear so many people that are still suffering from long COVID because that terrible virus causes inflammation in virtually any organ of the body.
No, no.
And yeah, and just feel so bad for patients that it's not your fault if you get COVID, but some people are just so unlucky and they're still suffering from the chronic fatigue or from brain fog, chronic pain, chronic shortness of breath, or permanent loss of smell.
Mhm.
So some of the symptoms could be just like severe fibromyalgia or like a severe concussion, but it never gets better.
Oh,
So
wow.
yeah, it's really a disaster for so many people in our community. So, and of course, a lot of people, too many people died from COVID, but so many people are survivors suffering still from long COVID. So even though it doesn't seem to be as aggressive and not as many hospitalizations compared to before, so I think we all developed some degree of immunity. We always should be on the lookout and kind of paying attention if there's some new, more aggressive strains popping up.
Mhm. We do track that, not to do another plug, but for the checkup, our PCN newsletter, we pay close attention to all that type of news that folks should be aware of or could be aware of. So for public health and all those types of sources. So consider subscribing if you're interested in keeping on top of those things. If you've been diagnosed with viral bronchitis, how long before you can expect the cough to go away? Can you take anything to help with the cough?
Well, your doctor, knowing your history and side effects of different medications, as long as he knows that you're not having any further active infection, people can commonly cough a month and sometimes a little bit longer. But if it's going on beyond a month, especially if you're older, like over 30, you should see your family doctor just to check to make sure nothing else is causing the chronic cough. But something simple like the over-the-counter medications probably don't work that well if it's
Mm,
persistent. Um, if there's some still upper respiratory symptoms, then sometimes the physician might prescribe a nasal steroid, which is quite safe and can dry up the sinus and nasal passages, which could be a trigger for a post-infectious viral cough. Sometimes we might prescribe some codeine, like in the form of Tylenol with a little codeine at nighttime for a few nights just to suppress the cough if
hmm.
that's the only time that someone's coughing so they can sleep.
Right. Okay. And then one final question. It says, so can a flu turn into pneumonia?
Sometimes influenza can be complicated by pneumonia. So when your immune system is compromised from the infection, you can get a secondary infection. Or influenza virus itself can cause a pneumonitis or inflammation in the lungs too. So it could be from the influenza itself, like a viral pneumonitis or pneumonia, or it can be a secondary virus or bacteria that jumps on board to join the party now that the parents have gone and the host is compromised.
Right. Well, just a comment. Sorry, Celine, I missed that. She said, I went to a party in January. 5 people got the flu from the party. One person got really sick and had pneumonia. So, and then her follow-up question was about, so can a flu turn into pneumonia? So just for some context there.
Oh, yeah. Yeah, certainly in that way, either from the virus itself or from a secondary infection.
Right.
Um, and this reminds me, about a year and a half ago, my wife went on a pilgrimage, like a bus trip to go to all these Catholic churches and shrines in Europe. And it was a lot of fun for her. Um, I didn't go. I've been to lots of churches when we've been to Europe. Um, but there were people that were coughing on the bus and not
Mm,
wearing face masks. And one older man in the group got sick at the end of the trip. He ended up in a hospital and ended up dying from respiratory failure. So even even if you don't have any underlying conditions, um, if you do have a respiratory infection, know that there's other people at risk, especially if you're in
right.
close quarters, like on a bus and in a group or in the same home or in a classroom, that you want to protect other people that are vulnerable. You can't always tell who is more vulnerable, but thinking about infecting other people because we share the air, we share the germs, and we still share responsibility to look after each other, even though it's not there's no mass band-aids. Um,
Right.
we should still remember that to think about other people when we're sick. Uh,
Yeah. Thank you. I think that's important to remember. Some of us forget. I'm just going to go to work. I don't feel that bad, but I'm coughing all over everything. Well, people don't at work don't appreciate that. Or when you go to the grocery store or something like that. So, anybody else have any questions? We still have a little bit of time. Thanks for joining us, Aruna.
the my next talk, if you want a little preview, we do have a video that I made a few years ago, which is kind of funny.
Oh, just to confirm, Dr. Wong, we're on Thursday, April 23rd. You don't
Oh,
have to
April.
work on a Friday. So,
Oh, okay, April 23rd. I put the
yeah,
wrong date on that.
that's okay. No problem. That's what you got me for. April 23rd. That's what's on the website. That's so it's a Thursday night,
Yeah, our usual Thursday night.
our usual Thursday. Yeah.
Yeah, so you
Dr.
could.
Wong couldn't do Thursday this week just because of his daughter's getting married. And so he's got some family
Yeah, we had
things
the
happening.
rehearsal on Thursday. I was gonna wear my tuxedo tonight. You wanted that. But I didn't have time to get it all together.
Yeah.
Is the video that we made a few years ago still on the new website? Because we made a video called The Lonely Patient's Guide to Hospital Land, where um, I'm in the scrubs. I kind of tell you how people are dressed in the hospital, and
Let me do a little bit. If you can keep chatting with people, I'll see what I
yeah,
can find. I
yeah,
think
because I got all
it's moved
dressed
over
up
to YouTube.
in scrubs and in a hospital gown just to orient you to the strange culture of hospital land where we obviously speak a different language. And there's so many different people, so you need to know who everyone is and reading name tags. But um, that talk will empower you. There's some handouts that you could bring in as well if you are going to the hospital for a minor or major thing, or you just surprised that a loved one or yourself is in a hospital. So there's handouts that we'll be giving you as well to kind of give you some tips on how to be an advocate for your own health in the hospital because things are so different in the hospital. Like when you see your family doctor and we're going to recommend a treatment or a medication, we're obligated to tell you risks and benefits. When we're ordering a blood test, I'm never going to order a blood test without your permission. So I explain what we're testing for. In the hospital, people are doing so many blood tests on you and you don't even know what they're checking, and they're not always telling you the results. It's so different from when you're outside of the hospital. And when you're in the hospital, because you're not even wearing your own clothes, you're kind of in a different role, and people tend to take a real passive role and not ask these questions. And it's really important that for any procedure, any medication, any test, that you know what it's for, what are the side effects, what are the risks that you should know about, what are the alternatives. So you won't be a pain in the neck. You'll just be an assertive patient if you ask those questions and get a clear answer. And that keeps you in the driver's seat, even though you're wearing a gown that's open up in the back and having to lie in a bed all the time and share a washroom. So that the goal of that talk is just to empower you so that if you are in the hospital or loved ones in the hospital, then you can make sure your voice is heard. I often have patients calling me from the emergency room asking for advice when they're about to see somebody and about to do some tests that are recommended. But as healthcare providers, we still have an obligation um, as doctors and nurses in the hospital to share that information. The nurses often will defer to the physician if you ask about those questions. And sometimes it's so hard to find out who the MRP is. That's the most responsible physician. So that's the one whose name is usually on your wristband and whose name is on the chart as the person that's kind of the go-to person that's directing care. So that talk will be helpful for all of us because at some point or another we will end up in the hospital or a loved one will be. So it's an essential just to make sure your wishes are respected, that you know what's going on, and you get the best outcomes.
That's awesome. So I popped the link to that video in the chat for you folks. So so definitely check. I was looking for a date of when we did it. It's not popping up, but yeah, those were great videos to shoot. You put a lot of work into those, so
Yeah, that was about
it's
10 years ago,
oh
at
yeah.
the beginning.
Funny that doesn't 9 years ago it says, yeah, that we uploaded it to YouTube. So again, I think we filmed them before that. So
Yeah, filmed at the old Burnaby Hospital.
the old Burnaby Hospital. So yeah, check out that video. I plucked the link into the chat and you can check out Dr. Wong. He still looks the same. Can't believe
Thanks.
it. Still the swimming. Anyway, so yeah, I think we just had some lovely thank yous from folks in the chat. So happy you were able to join us this evening. Um, we did it. 13 minutes to spare.
Well, thank you. Well, now
We're
that
so
it's dark, I'll
efficient.
give you back the rest of your evening. Thank you so much for joining me. It's really a pleasure to work with Leona, but also that you spend this time with me and hopefully share any valuable information with your loved ones and your neighbors and invite them to our next talk because it'll be useful for pretty well every one of us.
Absolutely. And just before when I end the webinar, there will be a 8 question evaluation. So if you wouldn't mind taking a little bit of time, Dr. Wong and I look at these after every talk. So your feedback is really valuable and it helps us plan. We'll be soon be planning our next season. So please take a couple of minutes just to fill that out for us.
Okay, and thanks, Leona, for all the things that you're doing and doing such a wonderful job, always with a smile.
I try. Thank you. Anyways, have a wonderful evening, folks. Take care.
Yeah. Good night.
Good night.